Begin. Hi, my name is Angela, and welcome to this PHA Live webinar. We will begin shortly. This is Fundamentals of Genetic Testing. Hello again. And while we're waiting for everyone to join us in for this webinar, I will like to take a moment to just share that this webinar will be delivered simultaneously in both English and in Spanish. In order to hear in your preferred language, you will have to make a selection. So if you look to the bottom of your screen on your toolbar, you should see a globe button that says either interpretation or language. Please select your preferred language from that button to hear in your preferred language. You would also need to select mute original audio in order to only hear the preferred language. So again, if you would like to hear this webinar in English, down at the bottom, you would click on that interpretation button and select English. And then if you would like to hear this webinar in Spanish, you would do the same. Down at the bottom of the toolbar, you would click the interpretation button and click Spanish, and then you would select mute original audio. Selecting mute original audio allows for you to only hear your preferred language during this webinar. So I will take a moment to continue talking right here to give you a chance to select your language, make sure everything's working properly for you. And then periodically, I will put these instructions in the chat. So those who join us a little bit later will have the same information. So again, to select your language, click at the bottom of the screen, the toolbar that says interpretation. It should be a globe, and you can select either English or Spanish. I would also like to take a moment to thank our international partners, TBX for Life and the Foundation Against Pulmonary Hypertension, for helping to bring this webinar and this lovely panel to you guys to present this information on genetics with PH. Also, I'd like to take a moment to recognize our sponsors of the PHA Connects program. We appreciate their support and recognize that they do not participate in the development of, nor do they endorse the content of this programming. As a nonprofit organization, we, PHA, relies on the support of its members to fulfill its mission. So hope that you will join us in our global network of PH patients, caregivers, donors, and healthcare professionals, and enjoy access to future PHA events, webinars, and publications. If you're already a member, thank you so much for your support. If you're not, please consider joining us by reaching out to memberships at phassociation.org. And additionally, some programming notes just to make sure you're aware. Following this presentation, we will have a Q&A option. To access the Q&A and submit your questions to our panelists, you will use the Q&A button on your toolbar. You can access that at any point in time during the webinar to submit your question. Also, following at the conclusion of the webinar, we will have a survey that pops up. We hope that you will complete the survey because this keeps us informed on the topics you would like to see in the future. And now for our esteemed panelists, our international panelists joining us from around the world today. It's very exciting to have you all here. Drs. Cruz, Utrilla, Prepa, Austin, and Bogar have spent the past few months making sure that this is the best presentation with the most up-to-date and relevant information for you. Again, they're joining us from around the world, from Spain, London, right here in America, and as well as Amsterdam. So we appreciate you and thank you. And now we will get started with the fundamentals of genetic testing. Leading us off will be Dr. Eric Austin, who will lead this presentation as well as moderate the webinar. Dr. Austin?
Thank you so much, Angela, and thank you to you and to our interpreter team and to my esteemed panelists who graciously put a lot of time and effort into this experience. And we hope this is a great one for everyone. We're going to go through and do a few slides of introduction, and then I'll pass the torch on to my colleagues. The first thing that we wanted to share with you is just a reminder that pulmonary hypertension has multiple different causes or associated conditions. And in the current structured classification system, we see that we have what we call group 1 pulmonary hypertension, which is globally referred to as pulmonary arterial hypertension. That's in your upper left on the slide. We have group 2, which is pulmonary hypertension due to left heart disease. We have group 3, which is pulmonary hypertension due to a variety of conditions that are lung disease specific and or cause low oxygen content or due to low oxygen content in the blood and in the inhaled gases. Individuals who have group 4 disease have chronic thromboembolic pulmonary hypertension associated most commonly with persistent embolisms or clots in their lungs. And group 5 is a catch-all basket for some things that are important but may not have been captured in groups 1, 2, 3, and 4. So it's due to other mechanisms, as you can see there. The reason we put this slide up is to highlight particularly, and I'll show you in the next slide here, Angela, that group 1 pulmonary hypertension or pulmonary arterial hypertension comprises the vast majority of what we know about the genetics of pulmonary hypertension to date. The types of pulmonary hypertension that are classified as pulmonary arterial hypertension include idiopathic pulmonary arterial hypertension, where we don't know why it has occurred, but we cannot discern an associated condition, nor genetic testing has revealed anything to date. People who have heritable pulmonary arterial hypertension, where they may have a family that is known to have 2 or more people who have the disease very definitively, or there's a gene mutation that has been detected in a person, and as a result, I beg your pardon, as a result, moving forward, that person has a disease that can be inherited that is heritable to future generations. Additional causes include drug and toxin-induced pulmonary hypertension, which may or may not be associated with genes, and other associated causes that are less likely due to what we traditionally think of as PH genes, including connective tissue disease, congenital heart disease, HIV, portal hypertension, and schistosomiasis. In some rare cases, you may see PH-related genes in those cases. There's a few additional causes as well down there that I won't go into at this moment, other than to say that pulmonary veno-occlusive disease very often now is associated with genetic variations as well that can be transmitted in the family and can be a heritable disease. Pulmonary capillary hemangiomatosis is probably on the spectrum of what we think of as written there PVOD. So they're often related diseases. Persistent pulmonary hypertension of the newborn occurs exclusively in a neonatal child age 0 to 30 days. On the next slide here, we see that multiple genes are now known to associate with group 1 pulmonary hypertension, which again is pulmonary arterial hypertension. Way back now, about 24 years ago, international groups discovered, as well as groups at Columbia University working as a team, discovered BMPR2. That gene at the time and to this day remains the most common gene found when we look for genetic causes of pulmonary arterial hypertension and we detect them in families or patients. But as you can see on the y-axis, which is the bottom strip there are now multiple other genes that have been discovered that are thought to associate with pulmonary arterial hypertension. Many of these, but not all, are definitively able to cause pulmonary arterial hypertension. On the y-axis, which is the up and down axis, you see what they say there is evidence points scored. And I only put that to say that the first approximately 10 to 15 genes in the list on the x-axis are pretty confidently now associated with pulmonary arterial hypertension that can be conveyed forward as a heritable disease. The other genes may well be, but the bulk of information to support their inclusion as definitive causes has not quite reached full available information, but we do worry about them as well. And on the last slide, before I pass it off, I just want to show you when we think about a disease that occurs in a person's family, we think about what's called a pedigree. And a pedigree refers to the notion that you have at the top there in a square, a male, in a circle, a female. And in a pedigree, a circle always connotes a male and a circle always connotes a female, at least by biologic sex. That those two top people in the first generation, generation one there, they have children. And as you can see there, they have lines that connect to one female circle and one other female circle. In that pedigree, they also have in the middle a male in a square, and then they have a female connected to the far left, a male connected to the far left female. This pedigree is showing that in that second generation, there are 3 biologic children of the first generation and one person who has had a child with one of the women in that generation. In the third generation, that couple that has children has 3 children. When you look at a pedigree like this, one of the common ways it's displayed is, as I said, a circle means a female, a square means a male. When the square or the circle have a gray color into them, that also means that the person has the disease that is of interest in that particular discussion. So in this case, the squares and the circles that are gray identify people who have pulmonary arterial hypertension in that family. So this tells me that this family is represented a family that has familial pulmonary arterial hypertension. And by definition, because there's 2 or more people, they have familial pulmonary arterial hypertension. So they also must have what we call heritable pulmonary arterial hypertension. It can be transmitted through the generations, as you see there. There actually are 2 people represented, one in a square in generation 3 and one in a circle in generation 2 that are not grayed in, but they have circles in them that are black. I did not put the circles in black perfectly in the middle, but they should be. And that identifies people who carry a risk for the disease in that family that is the major rare variation or mutation in that family. So there, for example, if that's a family that has a BMPR2 mutation that can cause pulmonary arterial hypertension, those 2 people carry that gene mutation, but they do not have pulmonary arterial hypertension to our knowledge. So they are carriers of the mutation of interest, but they do not have the disease. And that's important because it identifies the fact that we have people in that family who are silently carrying a risk for pulmonary arterial hypertension, but they may not have the disease, obviously. They may be completely healthy or they may have disease below the level of our detective ability, but those people can pass that gene mutation on to their children, which is not demonstrated in that pedigree. I think Dr. Cruz-Otria is going to show us a pedigree later, so we wanted to show that.
I would like to thank you, Eric. I would like to start also saying thank you to the PHA Association and also to the TBX for Life and to La Fundación contra la Hipertensión Pulmonar. And in my part, I would like to explain to whom we do genetic testing. By clinical consensus, we use it in idiopathic cases, but also in familial cases, and in cases of drugs or toxins associated with pH, as in the case in Spain with the toxic oil syndrome, but also we can have in this part of pH some cases associated with drug suppressants, appetite suppressants, or methamphetamines abuse. And this is because we know in these cases, the prevalence of genetic variants is much higher in comparison with other pH forms. We know that in pediatric cases with familial association, the probability of having a positive genetic result is as high as 80%. And in patients with idiopathic PAH, the probability of having a positive genetic result is as high as 15 to 20%. On the other hand, in the other PAH forms, the probability of having a positive genetic result is much lower. And also the clinical relevance of these genetic results is not very well understood. So the current consensus only recommend the use. They can't hear me. I don't know why.
I'm not sure why I am getting notifications. Hi, this is Angela again, that they can't hear you. I can hear you, but I am not sure what is happening.
Nobody can hear me?
No, I think your panelists, we can hear you fine. It may be an isolated issue at the user level. I'm not sure, Angela.
Okay, let me work on that. If you would like to continue, I'll try to work on it on my end. Sorry about that.
I'm very sorry. Nobody can hear me? So I can hear.
Yeah, Alejandro or Dr. Cruz Utria, I think your fellow panelists, we do hear you fine. We're not sure if this is occurring at the level of the person receiving the webinar or not. I think Angela's working on it.
Yeah,
Other people say they can
hear. So I'll just add in here, if you are trying to hear this in English, you should select English as your language. To hear in Spanish, you would select Spanish and then mute original audio, I believe. But I'm seeing that people can hear you fine, and then some people can't. And Dr.
This is probably the technical issue, so let's probably we will continue because this is technical issue maybe on the part of the connectivity issue maybe somewhere.
Let me check in. Dr. Utrilla, do you have English or Spanish selected as your language?
In English.
Okay, well, we'll continue and I'll try to work it out. I'm sorry about that delay. Let's continue.
No, don't worry. So in other cases, in case of clinical suspicion of PVOD, the current consensus also recommend the use of genetic testing. Could you put the next slide, please, Angela? Okay, and I would like to talk also about the benefits of doing genetic testing. And I will divide this in four parts. The first part is because we can phenotype our patient. We can discover some clinical characteristics after having a positive genetic result. And this is very important, as in the case in TBX4. Many of you probably know that TBX4 patients could have a specific clinical phenotype, so specific clinical characteristics. So these patients can have some skeletal abnormalities within the knee or within the feet, and also they can have some heart defects, or they can have also some lung parenchymal abnormalities. This is also very important in the case of PVOD, as Dr. Austin previously explained. Some patients can be diagnosed of pulmonary veno-occlusive disease after discovering a biallelic variant in this gene called EF2AK4. And these patients can have pulmonary edema after the initiation of drugs, of pulmonary vasodilators, and then can have a poorer prognosis also. So this is very important, discovering this gene in a PAH patient. And another example is having an HHT phenotype called hemorrhagic hereditary telangiectasia, and these patients can have nose bleedings since childhood, and they can also have some specific lesions within the mouth or within the lips. Another important point is when we discover genetic mutation, we can reclassify our patient from idiopathic PAH form initially, and then we can reclassify this patient to a heritable form. This is important for first-degree family members, or even more importantly, if we reclassify our patient to a PVOD form. Next slide, please, Angela. The third point could be to do a different treatment approach. If we discover a patient with a genetic mutation causing PVOD, we should be aware of treatment uptitration. And as I said before, many times we should slow uptitrate these patients because they can have pulmonary edema when using pulmonary vasodilators. But we also should be aware of referring this patient quickly to lung transplantation because the prognosis many times is poorer in comparison with other forms. And finally, as Dr. Austin said before, we can have a genetic mutation in an index case, and this is very important because we should use genetic testing in first-degree family members to screen for new cases of PAH. So this is my final slide.
Thank you, Angela. I will share my screen now, and hopefully the technical issues are getting resolved. So again, many thanks to the association and everyone, everyone else in the panel for this kind invitation to participate in this webinar. I'm a geneticist, so I'm going to give you an introduction going back to the basics of what we mean by genetic mutation and genetics in general. So just to show you, this is the fundamental structure where a DNA sits. It's called the chromosome. And chromosomes can be found within each of our body cells, within this sac-like structure called the nucleus. And if you, let's say, for example, collect a blood sample and have a look down the microscope at chromosomes, this is how they look like. So they look like threads, or sometimes we describe them as worms, children, and they have, you see, a particular length. So starting from chromosome 1, they can be quite long. And then if you go all the way down to chromosome 22, they become quite short. And the first 22 chromosomes are the same in men and women. And the last set of chromosomes is our sex chromosome. So men have an X and a Y, and females have 2 X chromosomes. So this is the chromosome set of a female because you have 2 X's. The rest of the chromosomes, you also have them in 2 copies, as you can see here. And you have 1 copy from your mother and 1 from your father. So we are a mix of both of our parents. And in this particular case, if you are quite careful, you can see down here, you see there are 3 copies of chromosome 21 instead of 2 copies. So this is an individual who has trisomy 21, and it is a female because she has 2 copies of the X chromosome biologically. Now, if, let's say, think of Google Maps, and this is the bird's eye view, if you really zoom in into chromosomes, then you see these structures here, and these are called genes. And like chromosomes, we have 2 copies of most of our genes, one inherited from our mom and one from our dad. And genes have those series of letters, which is our DNA code, which is A, T, C, and G. And when we say genetic mutation, or I can use the term gene fault, alteration, gene variant, essentially what we mean is that there is a spelling mistake or a problem within those letters. And sometimes you can have a missing letter, or instead of having a letter T, for example, you have a letter G. And that sometimes is enough to actually not allow that gene to work as it should. So you can think of genes like books, recipe books, that contain instructions to make up different parts of our body, or it tells our body how to grow and function. And essentially, if you have a fault within a gene, that sequentially affects something in our body, and in this case, it may cause pulmonary arterial hypertension. So there are two. Sorry.
I apologize. Can you go to slideshow view? We can't see your pointer.
You can't
the
see
top.
it. Okay.
Slideshow view from current slide. Apologize.
What's happened, Martina, is we're looking at your design
Yes.
view rather than your, the
Okay.
proper. Oh, yeah,
Okay.
thank you.
Is this the same problem?
Yes.
Hmm.
Is it popping up in two screens for you?
It is, yes.
If you bring over that main screen, or I can share, but I won't have your pointer. If you go again to slideshow view, and then from current slide, if you have two screens, you want to drag over the larger screen to your main screen that you were viewing.
Okay, I'm gonna try one last time. If it doesn't work, that's fine. I think you can just share.
Sorry about that. Yes.
Yeah,
Now we see the presentation.
is that better now? Okay.
Yes. Thank you. And I
Thank you.
apologize.
No worries. No, thank you. Can you see my laser?
It's perfect. Yes.
Okay, perfect. So yes, these are the chromosomes. It's a shame you missed all that, so I'm going to go through it again very quickly. This is a complete set of chromosomes, and this is what I meant by chromosome 1 to 22, same in men and women, and the sex chromosomes down here. And what I was just saying is that if you zoom in, you can see that we go from chromosomes to genes, and you have the series of the letters. And if you have a fault within these, then we have a so-called genetic mutation. Now, we have more than 20,000 genes in humans, but bear in mind that it's only approximately 5,000 of them that we have connected to a human condition. And new gene disease associations are being discovered literally on a monthly basis. So if you had a pulmonary hypertension genetic test 10 years ago and nothing was found, this doesn't mean that this test cannot be repeated and maybe something new will come to light. And that could be a spelling mistake within a gene that we weren't able to pick up previously, or it could be a new disease gene that we weren't previously aware of and we can now test for. And what type of genetic tests can we do? So we can do single gene testing. So if you think of genes like books, you open one book, for example, the BMPR2 gene, and you read the letters, all of them sequentially. And for example, you're looking for a spelling mistake, like instead of saying the car was red, it reads the car was red with a DD. And that sometimes is enough to actually not allow that gene to work properly and cause pulmonary hypertension. So it could be that subtle. However, I can tell you that it's now much more cost effective and faster to not just look at one gene at a time, but actually do a group of genes at the same time, and we call them gene panels. And for example, in the UK where I work, we have 11 genes where we have a definitive association with pulmonary hypertension, and we look at all 11 of them at the same time, and we screen for spelling mistakes. What we are now moving to is an even more sophisticated test, and we call those tests whole exome or whole genome sequencing, where you look in the entire library. So you sequence the whole 20,000 genes, and then you look for spelling mistakes within them. In terms of either particular chapters of interest, this is the whole exome sequencing, or whole genome sequencing, which you don't look at chapters, you look at absolutely everything. And sometimes you do a so-called gene agnostic approach, where, for example, you don't know what the disease gene is, and you're trying to discover it. But sometimes we even use it as a diagnostic test, because it's faster to actually look at all 20,000 genes simultaneously, but then only zoom in and open and read the books of interest. I think eventually everyone who has genetic testing will have whole genome sequencing. And I wanted to show you a copy of the genetic test report. So in the bottom here, you see a table of genes. And you see in this case, a list of all the genes that were analyzed, and next to it you see a percentage. So a percentage means how well we can read those genes, because sometimes genes are tricky. There can be lots of spelling mistakes within them that are normal variation in our DNA, and it can make it trickier for this gene to be read or a particular page to be read. In this case, you can see that the coverage was 100%. So this test is quite reliable in terms of screening those genes for faults within them. And out of these genes that were looked at, there was an alteration or mutation in a gene called SMAD9. And here you see it says DNA variant, and it gives you the exact position. So in position 166, there should be a letter G, but instead there is a letter C. And then here it shows you what is the effect of this on the product of the gene called protein. This is the genomic coordinate, so it tells you that that gene sits within chromosome 13, and it tells you exactly where it is. And zygosity means, remember how I said genes have two copies, we have them in two copies. Heterozygous means that only one of the two copies of the gene carries the fault, and the other copy of the gene doesn't. If it says homozygous, it means that both copies of the gene have the fault, and that applies to the PVOT that was mentioned earlier. And I wanted to show you how to apply this in reality. So again, going back to family trees that we commonly draw in genetics clinics. So you have this individual here marked in gray. So we know that he is affected and he has pulmonary arterial hypertension, and he is a male because he is a square. He's 45 years old, and let's say that he had a gene panel test. They looked at 11 genes that can cause pulmonary hypertension, and they found a spelling mistake within the BMPR2 gene. So we have made a genetic diagnosis in this individual, and we have an explanation for his pulmonary hypertension. Now, he has a female partner, and they have two children, a boy and a girl, age 13 and 8. He has a sister, age 40. And with that line with P here, it means that she's currently pregnant. And here we have another sibling, a brother who is age 38. And you see these are white, so presumably they're not affected. And this individual's father passed away, so the cross line means that they're no longer alive. They passed away at 64 years due to cancer. And his mother, aged 94, doesn't have any pulmonary hypertension. So there are lots of implications in terms of the genetic test result here. Obviously, the number one thing that this person will be preoccupied with is, what do I tell to my children? What do we do? Do we test them? What is the risk to them? And if you think about it again, that this person is heterozygous, so he has one healthy copy of the gene and one copy that has the mutation or the spelling mistake within it. When we have children, we split our two copies in two, and we randomly pass on one or the other to them. So the odds of the children carrying this gene change inherited by the father is 1 in 2. And that risk applies to each pregnancy. So 1 in 2 that child may have inherited the healthy copy of the BMPR2 gene, and 1 in 2 that they have inherited the faulty copy from the dad. And in terms of testing, we have to think about lots of implications. We have to think about the benefits and the risks. Because let's say if we know that with this particular gene, pulmonary hypertension develops in an adult, we wouldn't test a child because it could cause more anxiety as opposed to reassurance. And we also don't want to take away the ability of the child making decisions for themselves. So for adult onset conditions, we say to parents, come back when the children are 16 or older, and then we can think about testing them. But if we would screen the children earlier for signs of pulmonary hypertension, then absolutely we do test them, and we start investigations in them for pulmonary hypertension because this may have management implications. What do we do with this sister here who is pregnant? In this situation, if the sister would tell us, I'm really worried about this pregnancy, I would terminate a pregnancy that is affected with BMPR2 gene fault. Obviously, the problem here is that even if someone carries the gene fault, we can't predict if they're going to develop pulmonary hypertension, because the tricky bit is that not everyone develops it at the exact point in life. And it may be that someone carries this gene change and they're fine until their 60s, 70s, 80s. But let's say this individual feels quite firmly about it and they want the pregnancy to be tested. Then what we would do is we would rapidly test the sister, and then we would know if the pregnancy is at risk. And there are tests we can run during the pregnancy to see if that baby has inherited the gene change or not. And when it comes to parents, probably it came from the dad's side, because the mom at the age of 94, if she doesn't have any pulmonary hypertension, it would be very surprising to find it in her. But again, we would test the mother and try and see what's what. And sometimes gene changes occur out of the blue in an individual, and you test mom and dad and neither of them carry it, and it has started in someone for the first time. And that's not uncommon in genetics. We know that sometimes spelling mistakes in genes can happen spontaneously out of the blue. Yes, and now I'm going to stop here and I'm going to pass on to Harm. Thank you.
Yeah, thank you, Martina, and I'll carry on. I think you will continue sharing your slide. That's the easiest.
Yeah, if it's okay. Yes, thank you.
Yeah, please do. So thank you also for having me in this very important webinar tonight. So as Martina said, there's a chance that relatives are carrying the same disease-causing gene. And that chance is about 50% in first degree relatives, so in the children, but also in the siblings. If they would have a family member with the disease, with the hereditary PAH, they would have 50% chance of also carrying the gene. But we know quite well from all the data in BMPR2 carriers, we know much less about other genetic variants, but we know pretty well in BMPR2 mutant carriers that the chance of developing disease is not at all 100%. It's only about 1 in 3 of the carriers that will go on to develop pulmonary arterial hypertension. So even if you carry the gene, it doesn't mean that you will become sick. So that really affects the choices of whether you want to be tested or not. And what is also very important is that the chances for females and males to actually develop the disease are quite different. Unfortunately, females have a much higher chance of developing PAH when they carry the gene than males do. Females have about 40% chance of developing the disease when they carry the gene, and males only have about 14% chance to develop PAH when they carry a pathogenic variant in the BMPR2 gene. So it's quite a complicated issue whether you want to be tested and what the implications of carrying a gene are for different individuals. At the same time, we know quite certain that it has implications when you do carry the gene, because when you, as a healthy individual, when you know you do carry the gene, you have the opportunity of being followed up quite closely, and you have the opportunity of getting a very early diagnosis, which we believe will improve your chances, because an early diagnosis allows for early treatment and allows for better outcomes. Martina, if you can go on to the next slide.
Sorry,
Yes. So on the left, there's a little diagram of how we see that the disease develops in the carriers of the gene. And one has to realize that we usually diagnose patients with pulmonary arterial hypertension only when they develop severe disease, a disease that is severe enough for them to have signs of right heart failure. Because the symptoms that we know of pulmonary hypertension are those of impaired cardiac function, impaired function of the right ventricle, translating into decreased exercise capacity or palpitations or chest pain or edema. All those signs are signs of right heart failure, which is a consequence of really the pulmonary vascular disease, the lung vessel disease, which is the primary problem in pulmonary arterial hypertension. So what would be very preferable is to detect pulmonary arterial hypertension before right heart failure develops. and only at the time when there is a problem of the lung circulation. And initiating treatment before right heart failure develops leads to better outcomes. This is a strong belief. We don't have that much data in genetic forms of pulmonary arterial hypertension. We have to look at other causes of pulmonary arterial hypertension, where we know that an early diagnosis translates into better outcomes. And on the right, you see an example of patients with another risk factor for pulmonary arterial hypertension. It's connective tissue disease, scleroderma. And we know very well in those patients that an early disease before severe right heart failure develops allows for early treatment and much better outcomes. And genetic testing in relatives of patients with hereditary forms of pulmonary arterial hypertension along the same lines of thought could lead to an early diagnosis and better outcomes. Next slide, please. So around the world, there are different efforts to know more about this early testing and about early screening of carriers of mutant genes. There are very important initiatives at Vanderbilt University in the United States, in Paris, and we also have a program, for example, in Amsterdam. This is called the Dolphin Genesis Project, where we really try to look at those relatives of patients with hereditary PAH and those who carry the mutant gene to really look at new ways to diagnose the disease early, detect the disease early, treat early, and improve outcomes. And the project is not only intended to for an early diagnosis in those hereditary patients, but it also intends to understand a little bit more about patients who carry the gene but don't have pulmonary arterial hypertension. Because of course, when you carry this mutant gene in your cells, you don't only carry it in your lungs, but you carry it in every cell of your body. And this could also translate in, for example, a different cardiac function. And we still know very little about the implications of genetic mutations for other organs than the lungs. And by better screening and by better looking at supposedly healthy carriers of a mutant gene, we can understand more of the implications of genetic mutations for general health and also for the prognosis of patients with hereditary forms of pulmonary arterial hypertension. And thank you. Another benefit of having such a program, of looking very closely at healthy mutation carriers, it also allows us to look for early signs of pulmonary arterial hypertension in the blood or in different imaging methods that could help to diagnose pulmonary arterial hypertension at a very early stage, not only in patients with hereditary disease, but also in patients with other forms of pulmonary arterial hypertension. Because when you follow a group of carriers of the mutant gene, some of those patients will develop the disease, and you can look at earlier time points before these individuals develop the disease, whether any blood test or exercise test or maybe a CT scan or an MRI scan already had signs of early development of pulmonary vascular disease, not so much right heart failure, but early signs of lung vessel problems that are heralding the development of pulmonary arterial hypertension. And as such, the case of mutant gene carriers can serve as a model for discovery of new biomarkers of early pulmonary arterial hypertension. So this is what we are doing in the Dolphin program. We're following individuals with who are otherwise healthy but who carry the mutant gene. We do a whole range of tests like echocardiography, CT scans, MRI, exercise testing, blood sampling, and we follow them over time. And this allows some individual patients to get a very early diagnosis, improving their outcome, but also serves the PAH community at a larger scale to identify new markers of early pulmonary arterial hypertension. Is there? So I think we're ready for questions, Eric. I think.
Wonderful, thank you, Harm. What a beautiful set of talks. We're grateful to each of our panelists. I guess one question that I see coming across the panel that I think is helpful, and perhaps I'll have Dr. Prapamatina start with this if that's okay. From a genetic perspective, if you have a family member who has disease, but you're worried about your entire family, what would be the best approach? Would you test everyone at one time? Would you start with the person who has the disease? And how would one approach that?
So we always want to start by testing the affected person. And I think I saw in one of the submitted questions, someone mentioned, I have a family history of pulmonary hypertension. How do I get tested? We do not test unaffected individuals, because if you look at my genes, for example, and your genes, you're always going to find spelling mistakes. Doesn't mean that everything is disease causing. So in order to be able to do the best possible test without causing uncertainties, we always want to go and test the person who is affected in the family. So I would start with this and see if we find a disease-causing gene change, and then we open up testing to at-risk relatives. And usually, depending on the age of the individual, if it is a child, the first point of action would be to test the parents to see if it's inherited. And then we test the siblings and other relatives and so forth. If it is an adult, we may go straight to testing the children if there is a worry. And then, of course, again, we open up testing to everyone else. But we always start with the affected person. And if there are multiple affected individuals and we have the option, we go with the most affected person, the one developing the disease at the youngest age.
Thank you. Thank you. Yeah, I think that's a really common question that we get, so we appreciate that. Another question that we have, Dr. Cruz-Ochilla, was this notion of, should an idiopathic pulmonary arterial hypertension case be tested in the current era? And if so, what would be the benefit or the downside? I think we have some people who would be interested in testing, but it's not clear to them and their team whether an idiopathic person should be tested.
Yeah, the current, I don't know if you can hear me now. Okay. The current recommendations are that we explained before. We should test all the cases of idiopathic PAH, because we know that almost 15 to 20%, depending on its study, have a genetic mutation, although they start with the diagnosis of idiopathic PAH. So although 80% don't have a genetic mutation, 15 to 20% will have the genetic mutation, and they will be reclassified, and the family members can be screened for PAH. And also, this is important because we can have some clinical features that were undiagnosed before, and we can find it after we find the genetic mutation. So the recommendation is to test all cases of idiopathic PAH, but of course we have to translate this into clinical practice, and this depends on each specific country and on each specific center. I mean, if we have a young patient, the diagnostic yield will be much higher. And if we have an old patient with PAH, idiopathic, the diagnostic yield will be lower. And this is possibly the reason why not all patients with idiopathic PAH are tested. I don't know if you want to add something.
I feel the same way, that all idiopathic PH patients should be tested. My experience in North America has been that in pediatric cases, that's fairly well absorbed now, accepted. And in individuals in adult care centers, sometimes there's a little bit more reluctance because of the concerns that were raised appropriately in some of the questions here. You see, how does this impact my insurance, my future care ability? how does it, how much does it cost? And those questions are difficult to answer sometimes because they do vary according to a person's insurance provided within the United States, at least according to what their physician and their plan would be, or their provider and their plan would be. We do have, and I put in the chat, some protections in the United States for genetic information that is acquired in terms of some aspects of future care. But it gets to another question that I was going to ask Dr. Bogard that someone asked. I guess a twofold question. Number one, if you find a mutation in an idiopathic PH patient, does that change how you care for them in the current era? And number two, do you think we will get to a point where that might alter our care approach in any way, if not a lot now?
Yeah, those are two excellent questions. So there have been quite a few detailed cohort studies looking at patients with pure idiopathic pulmonary arterial hypertension and those with hereditary PAH, particularly those with the BMPR2 mutation. And those cohort studies showed that patients with carrying pathogenic BMPR2 mutation did have a much more severe disease course. So this would lead to physicians to be very vigilant with relatively aggressive treatment, maybe early prostacyclin treatment, early referral for transplant. So this surely has implications. Funnily enough, there is a pretty strong sense, like in many international centers, that now with that approach of very early aggressive treatment in patients with hereditary PAH, their outcomes have actually become very good, and maybe even better than a lot of patients without carrying the mutation, because we are so vigilant and we treat them so relatively aggressively. So those old cohort studies with pretty poor outcomes in hereditary PAH may not be entirely applicable anymore. But still, I think the information that someone has this mutation really leads to at least very vigilant doctors and very careful management of those patients. So far, it doesn't lead to a different treatment. Patients with hereditary PAH are treated pretty much the same as those with idiopathic PAH in terms of the compounds that we use, the different drugs. There's a new development, a very interesting development in pulmonary arterial hypertension with sotatercept, a drug that really targets one of the pathways that is frequently implicated in hereditary forms of pulmonary arterial hypertension. So one could have the expectation that patients with gene mutations would benefit more from that treatment. But so far, the data doesn't show that. It seems like patients respond quite similarly to this new drug.
Thank you. That's really a nice overview and helpful. Dr. Martina Prapa, I was going to ask you, there's some questions that I'm trying to keep up with. I apologize for my delay if I've missed your question. So the notion would be that my child or me seems to have a condition that really would likely to represent a gene, for example, a mutation in TBX4. What if someone has some of the features that one might associate with that disease, with that gene, but are not expressed? I mean, that the phenotype is expressed, so the person has some clinical features, but when we do genetic testing, we do not find a mutation in that gene. Could it be that we missed it, or could it be in some friend genes that we're learning about? How would you think about that person if, say, they had some patellar or knee irregularities and some pulmonary arterial hypertension, and they were thinking TBX4, but they did not find it?
Yeah, it's a very good question. So we do see lots of patients like that in the genetics clinic, where we are 100% sure that there is a genetic diagnosis, but then we run the genetic test and we don't find the gene faults, and we're all taken by surprise. And in this example of TBX4, one thing that I didn't mention in my talk, remember I talked about chromosome testing and gene testing. Sometimes it could be a chromosome fault, and that may not be picked up by a gene panel test. So for example, with the TBX4 gene that sits in chromosome 17, you may have a small section of the chromosome 17 missing that takes out a copy of the TBX4 gene as well, and therefore causing TBX4 syndrome. But when you do a gene test, sometimes having a whole entire copy of TBX4 gene missing is not being picked up because of how the test has been calibrated. So this is where geneticists would be very helpful to be involved, because that geneticist would have said, why don't you look at the chromosomes as well, for example? Now, another reason that this may occur is because the result is only as good as the current test technology. And remember, I'm taking to the speakers, we talked about the audience, we're talking about whole genome sequencing. And whole genome is where we look not just the important chapters of the book, but the bits in between as well. And this is the so-called non-coding bits of the genes, where we know that they're not directly involved in making up a recipe, but they may still be important. So now there's a lot of work being done in that field, and we're finding bits within those important chapters where if you have a fault within them, you can develop a genetic condition. So my advice to this family would be check the chromosomes and also think about doing a whole genome sequence test.
Oh, that's a great advice. Okay. Dr. Cruz, what do you tell people? We've seen a lot of questions both before and during this. I was tested 8 years ago, and my doctor said, great news, we cannot find a variation, but we may or may not now, today, 8 years later, think, hey, maybe we should retest, or maybe there's a new family member. How do you approach genetic testing over time as we accrue knowledge?
Yes, this is a great question. Of course, we can retest, but we should know that the most possible thing here is that you still don't have a genetic mutation, because the first genetic mutation discovered were the most frequent genetic mutations. But of course, the approach here is to talk with your geneticist and ask if we can do the genetic test now with the current knowledge and repeat the test. Many times we have the blood samples freezed in the lab, so we can retest with that sample. And we don't have it, we can have a new blood sample and talk with our geneticist. So our response is, okay, we can retest, but you should know that probably you don't have a genetic mutation now.
Thank you. Yeah, it's such a common question that comes up. I'm going to go quick only because we're running out of time. Dr. Bogart, as a cardiologist and a PH specialist, we got one that I think is nifty. People with congenital heart disease, sometimes some mixed feelings in North America about whether we test them. How do you approach them from a genetic testing perspective?
Yeah, that's also a great question, because several of the genes that have been implicated in PH also are known to be associated with congenital heart disease. There are some cases with BMPR2 mutations, TBX4, but also SOC17. Other mutations that have been implicated in PH also have associations with congenital heart disease. So yeah, at least in the Netherlands, the approach is quite liberal. So it would be easy to have genetic panels for PH also being employed in patients with congenital heart disease. But I'm not sure about the situation in North America, whether this is reimbursed as well.
It's interesting, it often is fairly well reimbursed, but it's not as ubiquitous, it's not as commonly used. It depends on your center. I know some centers do it routinely for any PAH. I'll hit a quick few things right quick. There's several questions about vasodilator responsivity and calcium channel blockers and genes. To our knowledge, there's not separate genetic variations for responsivity and not, although I know there are studies going on investigating that question. We do know that people who have at least a BMPR2 gene mutation are less likely to be calcium channel blocker responsive and also less likely to be vasodilator responsive in the cath lab at diagnosis. I also want to give a shout out to you, Dr. Bogart. Multiple people have been so thankful to have your care over time and have mentioned that, which is quite nice. I want to thank so much Dr. Cruz-Ortilla, Dr. Papa, Dr. Bogart, and the PHA. Angela, I need your guidance here. We're coming up against the top of the hour, and I wanted to pass to you and tell us what you need us to do.
Yeah, thank you so much. We had many more questions come in, and unfortunately, we are out of time. So I do want to take this moment to thank our panel, Dr. Austin, for moderating, everyone who tuned in and shared questions. We could have gone on for another hour, I'm sure, sure of it with the questions we got in, but I think it's great information. I just wanted to share, we will record this. We are recording this, and it will be posted to our website shortly. It's usually a couple of weeks turnaround, but it will be posted to our PHA classroom. I believe I shared that in the Q&A. Someone asked about the recording. So don't worry, you will still get the information, and it even picked up the part where the sound wasn't working. So you'll still be able to hear that part. I just want to take a moment real quickly before we leave you to invite you to join us at the PH 2024 International PH Conference and Scientific Sessions. It's a wonderful opportunity to connect with patients, caregivers, and medical professionals for a weekend filled with connection, education, support, and fun. There's still time to register, and I will put that link in the chat for you. If you are interested, please feel free to register and join us. I will be there. And also, reminder, there is a survey. Once we conclude this webinar, it should pop up automatically for you to complete. Again, that helps us to know the topics you're interested in. So again, thank you to our panelists. Thank you for joining around the world. This was very exciting. We hope you enjoyed this topic, and we will see you next time. Bye, everyone.
Thank you.
Bye.
Bye.
Bye. Thank you, everyone.
Thank you, friends in Europe and here in North America. I appreciate all of y'all.
Thank you.
Great to be there.